So my name is Boris Hadaschik. I'm a urologist based in Essen in Germany, and I'm heading the department here. And before I was based in Heidelberg, where I did a lot of research on PSMA-PET tracers. At ASCO 2023, we try to answer the question whether there is correlation between PSMA-PET and long-term outcome, because as you know, the EAU guidelines currently caution clinicians to act on PET imaging because we don't have enough data correlating PET as a biomarker with long-term outcomes. And for this purpose, we used a cohort of 200 patients that we have published on before in clinical cancer research in 2019, looking at molecular imaging, so PSMA-PET, in a cohort of patients with high-risk non-metastatic castration-resistant disease. And you all remember that this entity of non-metastatic CRPC was used to seek approval for novel drugs in the past. So we now have 3 drugs approved in this disease space. It's apalutamide, darolutamide, and enzalutamide. But from a clinical perspective, non-metastatic CRPC is a rare entity. And we asked in 2019 the question, what happened if you use more sensitive imaging? So we used PET and we queried in an international group of 6 large volume PET centers, these centers, and we identified 200 patients where we had conventional imaging without metastases and PSMA-PET in men with CRPC. So in this study that was published in 2019 showed that in more than half of these patients, we found distant metastases on PET imaging. This was kind of a descriptive publication at that time, just demonstrating that if you use better imaging, there is stage migration. And then we looked in a post-hoc analysis at individual data of Spartan phase 3 patients, and we are not able to find a patient population within Spartan where all patients have high risk, so a short PSA doubling time, CRPC. All these patient groups defined also by PET imaging were benefiting from systemic treatment. But now I think this data we presented at ASCO is important because we correlated PET to longer term follow-up. So the same patient cohort of 200 men was follow up now for up to 9 years to find out what happened. We identified in our group, now with overall survival as the primary endpoint, that men that present with polymetastatic disease on PSMA-PET are at higher risk of dying from prostate cancer. Similarly, men with a high PSMA avidity, so a high positive signal on PSMA-PET, have a shorter life expectancy. So this tells me as a clinician that PSMA-PET really is providing biologically important information. And men with a lot of disease on PSMA-PET are a higher risk group within this mixed bag of high-risk nmCRPC. The other risk factor that we identified in our select cohort was that men with pathologically positive lymph nodes are at higher risk of dying as compared to men who have had prior radical prostatectomy without lymph nodes. This is not surprising and just confirms what we have observed before. We also looked at treatment that was initiated following PSMA-PET, and this was at a time where the drugs for nmCRPC were not approved yet. As you would expect, the clinicians acted on imaging. So if there were men with local disease or pelvic disease only, then curatively intended local therapies were applied, such as salvage radiotherapy or SBRT, while if men had more advanced disease on PET imaging, systemic treatment came into focus. So we asked the health authorities whether we could apply, for example, abiraterone or other drugs for mCRPC at that time. And the overall outcome of the study is that our 200 men patient cohort was living for a median of 74 months, which is comparable to the apalutamide arm of Spartan. So telling me that it was reasonable to really act on imaging. But the most important key takeaway is that PSMA-PET really is a useful biomarker. And now the challenge is that we have novel imaging that is more sensitive, but as shown in Pro-PSMA, for example, also more specific, is the new gold standard. But our treatment evidence is really based on conventional imaging. So there's a challenge, and we now need to really build bridges between the present with PSMA-PET and the past by embedding PET imaging in prospective clinical trials, because only these will really pave the way for PET to replace conventional imaging, because conventional imaging is really the basis of our decision making right now. So I caution you that just based on our data, you routinely use PSMA-PET in nmCRPC, because as we have shown in 2019, these men really, if they have high-risk disease, they benefit from systemic treatment. And I think there are other indications where PSMA-PET really is more useful, such as biochemical recurrence, primary staging, and to test eligibility for radioligand therapy in mCRPC. Yes, certainly our results will have clinical impact because they correlate imaging with long-term oncologic outcomes. And this is what is missing right now to really put PSMA-PET a little bit more prominent in the European guidelines. Because, I mean, I clearly understand the guideline committee, and I'm a close friend of Nicolas Mottet, but to completely disregard PET imaging in decision-making is something that is not really useful in clinical practice, for example, in primary staging. If I know by PSMA-PET that this patient has distant metastases that I don't see on conventional imaging, it's completely different communication with the patients when I discuss with him the adverse events or effects of local therapy, such as prostatectomy or radiotherapy. So it is really helpful to manage patient expectations. But on the other hand, you have to discuss with your patients what we need, what we know on solid ground, like clinical studies based on conventional imaging, and what to expect, what can novel imaging bring in. So I think it is important that we need correlation between imaging and long-term outcome, and we are waiting for this, for example, with the Pro-PSMA study in primary staging. But I'm very optimistic that PSMA-PET really will become the novel gold standard for imaging in prostate cancer in various indications. And for example, the NCCN guidelines are already embracing PET imaging for staging of prostate cancer patients in nearly all possible clinical scenarios.